So good morning to all of you. So this is the second class on musculoskeletal system. So in the previous class we had discussed so many aspects of various bone lesions, that is genetic or it could be related with infections. So today I'll be concentrating mainly on bone tumors followed by skeletal system. Okay. So bone tumors. So these bone tumors develop when cells within a bone divide uncontrollably, forming a mass or lump of abnormal tissue. So all of you know what is neoplasia. So it is neoplasm of the bone, that's all. So bone tumors are diverse in their gross and morphological features, and they range in their biologic potential from the innocuous to the rapidly fatal. So bone tumors are classified according to the cell of origin. So before that, these benign tumors, malignant tumors, all these things you have come across, you should have some basic idea about. In the bone, there is something called epiphysis, metaphysis, and diaphysis. So where exactly the tumor arises, whether it arises from the epiphysis, metaphysis, or diaphysis, that I'll be discussing later on. So in bone cancer, this is a normal bone wherein you are having the cartilage, you are having this articular cartilage, bone, and this marrow. So in case of cancer bone, the epiphyseal line or cartilage or sometimes the compact bone, or it could be the spongy marrow, any of those things can go for this malignancy, or there could be metastasis of the cancer from primary at different location. So what are all the risk factors for bone tumors? One is genetic disorders like Lee-Fraumeni syndrome, Rothman-Thompson syndrome, retinoblastoma, that is RB gene, then Paget's disease, radiation, bone marrow transplantation, injuries it doesn't cause. Coming to this Lee-Fraumeni syndrome, it makes people much more likely to develop several types of cancer, including breast cancer, brain cancer, osteosarcoma, and other types of sarcoma. So most of these tumors have mutation of P53. P53, it is a tumor suppressor gene. Once the tumor suppressor gene mutation occurs, it cannot perform its function properly. Hence, what happens? The oncogene or the tumor will continuously multiply because that anti-tumor effect is removed. It's not there. So Rothman-Thompson syndrome, children with this syndrome, they are short, have skeletal problems and rashes. They also are more likely to develop osteosarcoma because the abnormal changes in the gene REQL4. So RB gene, as all of you have read in neoplasia chapter, mutation in RB gene or mutation in P53 causes malignancy. So those with this mutation usually have increased risk of bone or soft tissue sarcomas. Then radiation therapy, which is used to treat retinoblastoma, that has also got high risk of developing malignancy. Then Paget's disease has got high risk of chordomas during childhood. Radiation, bones which are exposed to ionizing radiation have high risk of developing bone cancer. The bone marrow transplantation, the osteosarcoma have been reported in few cases which who have undergone bone marrow transplantation, that is mainly stem cell transplantation. According to WHO, based on the cell of origin, cartilage tumors, oncogenic tumors, fibrogenic tumors, Ewing's sarcoma, fibrohistiocytic tumors, hematopoietic tumors, and giant cell tumors. Other tumors are notochord tumors arising from the notochord, vascular tumors, smooth muscle tumors. Then there are miscellaneous lesions of the miscellaneous tumors. So this is the entire spectrum in a nutshell, which is the histologic type, that is cell of origin. What is a benign? What is its malignant counterpart? So hematopoietic cells, most of them, they can become lymphomas, myelomas, Then chondrogenic, benign are chondromas or osteochondroma, chondroblastoma, chondromyxoid fibroma. Then malignant chondrosarcoma, dedifferentiated or mesenchymal, osteogenic osteoma, osteoblastoma, and osteosarcoma. So for the exam point of view, you have to know something about osteosarcoma. Many times it has been asked in your exam. Giant cell tumor, Ewing sarcoma, then fibrous histiocytes, cell of origin. Benign tumor is fibrous histiocytoma. Malignant fibrous histiocytoma is its malignant counterpart. Then fibroma, fibrosarcomas. Tumor arising from notochord, that is chordoma. So these are the various tumors. So here you can see from the epiphysis, the tumor which arises is chondroblastoma. Then from the metaphysis, osteosarcoma and chondromas, diaphysis, adamantinoma, osteoid osteoma, and chondromyxoid fibroma. Same, the round cell lesions, they all arise from diaphysis, that's Ewing sarcoma. Giant cell tumor arises from the epiphysis, aneurysmal bone cyst, then bone, that is cortical, fibrous cortical defect, all these arise from the metaphysis. Less than 30 years, most common tumors are osteosarcomas, osteochondroma, enchondroma, osteoid osteoma, and fibrous dysplasia. Whereas more than 30 years age group, metastasis is more common, and chondrosarcomas, again osteosarcoma, different variants, enchondroma, bone infarction, they are all same. So benign versus malignant, already you know this one. In benign, there are well-defined sclerotic borders, lack of soft tissue mass, solid periosteal reaction can be seen at geographic bone destruction. Whereas in malignant, interrupted periosteal reaction, moth-eaten or permeative bone destruction, soft tissue mass, then wide zone of transition. Surrounding the tumor, you will have that transition area wherein plenty of these inflammatory cells are seen. We'll begin with osteoid osteoma. It is a benign tumor. By definition, it is less than 2 centimeters, usually occurs in teens and 20s. Male are more commonly affected. The commonest site is femur tibia, and it is painful lesion, usually occurs at night, and it is relieved by aspirin. So here you can see the tumor. This is that lesion. Here you can see again, this is the tumor area where you are seeing plenty of this bone trabeculae. Osteoblastomas, they involve spine more commonly. It has dull aching pain, but it doesn't respond to aspirin. That's how you need to differentiate osteoma from osteoblastoma. So both of them, they can be treated by conservative surgery, but it recurs if not excised entirely. So here you can see that lesion. Then this is that histopathological section wherein haphazardly they are arranged the bone trabeculae. So what is the differential diagnosis between this osteoblastoma and osteoid osteoma? In osteoid osteoma, more osteoid trabeculae with continuous and regular bone formation is seen. Stromal reaction is very less. Multinucleated giant cells are more in number. They are also they are seen very rarely, whereas they are seen in good number in osteoblastoma. Fibrous stroma is more, and trabeculae with discontinuous and irregular bone formation is noted. Size is more than 2 centimeters, whereas osteoid osteoma it is less than 2 centimeters. Pain, it is inconsistent or it may not be present in osteoblastoma, but pain is nocturnal and it is always present in osteomas. Commonest site of osteoblastoma is vertebral column, whereas osteoma is proximal femur. So both are benign tumors. Next, coming to the important topic, osteosarcoma. It is a malignant tumor in which cancerous cells produce osteoid matrix or mineralized bone. It is one of the most common primary malignant tumor of the bone, occurs in almost 20% of all the primary bone cancers. It has bimodal age distribution, that is less than 20 years or elderly age group. Male is to female ratio is 1.6 is to 1. The site, most common site is metaphysis of long bones. Please note down this one. Metaphysis of long bones, usually distal femur or proximal tibia. The presentation is painful progressive enlarging masses. Sudden fracture can occur, which usually will be the common first symptom in case of osteosarcoma. Metastasis, it's usually metastasis to the lungs, bone, and brain. So, as I told you earlier, distal femur or proximal tibia and also proximal humerus. These are the commonest sites. Less common sites are hip bone or radius, etc. So what is the pathogenesis? Mutation in RB gene has high risk of developing osteosarcoma. So in the exam you have to write mutation in P53 gene and RB gene and also overexpression of MDM2 genes. These are the genes which are responsible when mutation occurs, it is responsible for developing osteosarcoma. So this P53 gene or retinoblastoma gene, all are these tumor suppressor genes. Site of origin, it could be intramedullary, intracortical, or it could be in the surface. Histological grade, it could be low grade or high grade. It can be primary or secondary to pre-existing disorders. The histological features, based on that, it is classified into osteoblastic, chondroblastic, fibroblastic, telangiectatic, small cell, and giant cell. So here you can see that periosteum is elevated. It has formed almost like a triangle. This is the Codman triangle. And the periosteal reaction, it appears in the form of sunburst pattern on radiology. So most of the tumors, they appear bulky, gritty, gray-white, hemorrhage and cystic degeneration are reported. Usually they destroy the cortical bone. They spread along the medullary cavity, penetrate the epiphysis, and they enter into the joint. That is the specialty of osteosarcoma. So here you can see almost this tumor, you are seeing areas of hemorrhage and necrosis. It is extending up into the cortex and also it is present within the medulla. It is invading in this form. Here also you can see it has extended into the soft tissue. So here all these areas you can see this osteoid formation. These are all the tumor cells. Little high power you can see these tumor cells and the tumors are cells are producing osteoid new bone formation. Please note down that new bone formation is formed by the tumor cells here. That is the speciality of osteosarcoma. Tumor osteoid we will call that as. So hematogenous spread, it is very common. 10 to 20% have pulmonary metastasis at the time of diagnosis. So treatment is multimodal, chemotherapy followed by surgery. Outcome of patients with a metastasis are very poor. Next, coming to this cartilaginous tumors, chondromas, osteochondroma, chondroblastoma, chondromyxoid fibroma, and chondrosarcoma. These are all the various cartilage tumors. So in chondroma, it is the common tumor of hyaline cartilage that develops in the hand, femur, tibia, or humerus. The only symptom is mild ache. Pathological fractures may occur. So here you can see this is the tumor wherein plenty of cartilage areas are seen here. Here also you can see that cartilage areas and microscopy that hyaline cartilage you can see here. So lobules of hyaline cartilage are seen which contain mainly benign chondrocytes and endochondral ossification can be seen. So osteochondroma, the second one, it's also known as exostosis. It's a benign cartilage cap outgrowth. It has got a slender stalk. It also arises from metaphysis of long bones commonly seen in adolescents. So this is very commonly seen. So it's almost like this. If you see this one, it slowly grows like this, grows and it forms it has got a stalk. And you are seeing a cartilage cap with bone and bone marrow. So this entire thing is known as exostosis, also known as extra growth. So on radiology also you'll be seeing similar pattern wherein a stalk is seen. This is a gross feature of how the stalk appears along with the marrow. This is the cartilage cap. So microscopy you are seeing this cartilage cap. Center you are seeing bone trabeculae with bone marrow. This is osteochondroma. Third one, chondroblastoma, arises in the epiphysis. It is seen in males under 20 years of age. Femur, humerus, and tibia are commonly affected. So here you can see the tumor. This entire thing is the tumor, areas of hemorrhage and necrosis. It's a lytic lesion. On microscopy, you will be seeing polyhedral chondroblast. Please note down this one. Polyhedral chondroblast with well-defined cytoplasmic borders. The nucleus will have longitudinal grooves. Mitosis, necrosis, they are present. Underline this one. Chicken wire calcification is present, and osteoclast-like giant cells are also seen. So here you can see almost all the cells, they are well defined. You can appreciate the morphology of the cells, individual cells, and in between you will be having some calcified areas like these dark blue color areas. They are all forming, appearing in the form of chicken wire. So some giant cells you are seeing, and IHC is positive. So these are all calcified areas. Next one, chondromyxoid fibroma. It is rare. Males are commonly affected, and it usually affects in the teens. Small bones are commonly affected. You can see this is the tumor. So it's also a lytic lesion. Chondromyxoid stroma is seen with stellate type of cells. Chondrosarcoma. This is malignant tumor of cartilage forming tissues. It could be conventional, that is regular routine chondrosarcoma, or it could be chondrosarcoma variants. The possible etiology is the patient should have underwent, means he should already be having enchondroma, osteochondroma, chondroblastoma, or Paget's disease. Any of these underlying diseases are predisposing tumors for chondrosarcoma. So conventional chondrosarcoma, it either can be central, peripheral, or extracortical. The variants are clear cell, myxoid, mesenchymal, and dedifferentiated. So here you can see this is the tumor, cartilage tumor. Here you can see plenty of cartilage-like areas with the nucleus which is showing pleomorphism, having prominent nucleoli. Here also the tumor, it is the borders is not well defined and it is infiltrating into the underlying stroma. Then muscle. So this was about bone tumors. I just told about bone tumors and cartilage tumors, benign and malignant tumors. Okay, that completes about bone. Next topic is about muscle. So in muscle, yeah, all of you know that skeletal muscle, cardiac muscle, and smooth muscle. Three types of muscles are present. Yeah, so the topic here will be mainly about skeletal muscle. What is the normal function of that? How it functions? Then what are the uh, diseases affecting this skeletal muscle? Because cardiac muscle and all has already been discussed in CVS, cardiovascular system. So skeletal muscle, more than 600 muscles are present in the body. So the muscle structure of muscle, I'll just give a brief introduction about this muscle cell structure for another 3 4 slides. Then I will at least 5 6 slides I think. Then I will start with this diseases. So as all of you know that muscle cell, it has got a sarcoplasm, sarcolemma, and sarcoplasmic reticulum, which mainly stores calcium. So here you can see this is the muscle fiber, and here you can see this axon, that is a muscle fiber nucleus. These are the axons, and this is the junction which is more important, wherein that synaptic cleft is present, synaptic vesicles are present in the axon end, that is, and here you are seeing plenty of mitochondria on both sides. This is the folded sarcolemma. These are all the, this entire thing is one muscle bundle. You are having multiple, this thing, what is that? Sarcolemma. This is the sarcolemma, this is the nucleus, and you are having thin and thick filaments here. You are also seeing that yellow colored mitochondria here in between. Then you are having the sarcoplasmic reticulum, then opening into the transverse tubules, that is cisterna of sarcoplasmic reticulum, transverse tubules. The proteins which are mainly present are thick filaments and thin filaments. This you should know. Thick filaments, myosin, mainly required for contraction of the muscle. Thin filaments are actin, troponin, tropomyosin. Then there's a sliding filament module. So here you can see this is the entire skeletal muscle fiber. You are seeing that sarcoplasmic reticulum, and these are the Z lines. This is one sarcomere, which mainly consists of thick and thin filaments. These are the thin filaments. These are the thick filaments. That is myosin and actin. This entire thing is a myofibril. So multiple myofibrils are present in the entire skeletal muscle fiber. So inside this you are having H zone, Z zone and M line in between. So we call I band and A band. So this is this myosin molecule, myosin filament, and you are having actin filament, which is composed of troponin, tropomyosin and actin molecule. So all the three are present together. So this is a relaxed muscle wherein ADP with phosphate it is present here on the myosin area, whereas actin, troponin, and tropomyosin are present here. So during contraction, there is release of this calcium which binds to this troponin. Once it binds, that ADP and phosphate becomes ATP, and this ATP will cause it will pull down this myosin, resulting in contraction of the muscle. This process occurs. This already have discussed. It has been discussed in physiology for you. So this is the A band. In relaxed, how it will be. In contracting, it will be overlapping here. This is fully contracted. This is completely relaxed. Now coming to the diseases of muscular dystrophy. So what are the causes? It could be inherited or because of dominant or recessive genes. Depends on the age when symptoms appear and the types of symptoms that develop. Risk is because these are inherited disorders. That risk include family history of muscular dystrophy. So please note on this one, muscular dystrophy is a heterogeneous group of inherited disorders recognized by progressive, degenerative muscle weakness and loss of muscle tissue. Usually started in this childhood. It affects muscle strength and action. Please note on that important. So muscle strength and action mainly that is targeted here. It could be a generalized or localized one. The skeletal muscle and other organs may involve. What will happen if a muscular dystrophy occurs? So the patient will be having difficulty in walking or maintaining posture, muscle spasms, neurological or behavioral, or cardiac or other functional limitations can occur. So this is the normal biceps, how it is, biceps with muscular dystrophy. This is brachii muscle wherein biceps brachii, which is normal, is atrophy. So there are different types of muscular dystrophy. For you, important is that Duchenne muscular dystrophy and Becker muscular dystrophy. Most commonly, if at all it is asked, Duchenne muscular dystrophy can be asked. The other muscular dystrophies are congenital muscular dystrophy, limb girdle muscular dystrophy, facioscapulohumeral muscular dystrophy, Emery-Dreifuss muscular dystrophy, distal muscular dystrophy, myotonic and oculopharyngeal muscular dystrophy. So first one, Duchenne's muscular dystrophy, the you can just see this one in all these areas. In Duchenne muscular dystrophy, how much amount of affected muscle groups are seen, whereas in other muscular dystrophy it is a bit limited. Here it is very high in this and limb girdle. So what actually happens here is the etiology is there is a single gene defect, that is dystrophin is absent. So once there is absent dystrophin, it results in Duchenne's muscular dystrophy. So what is the actual function of this dystrophin? Dystrophin, it will bind with this actin binding region here on the actin filament, and it will bind to the sarcolemma or the muscle with linking proteins, so that dystrophin associated glycoprotein complex, that's also seen here. So it will bind and it mainly helps in contraction of the muscle. So whenever there is dystrophin deficiency, abnormal cell membrane with increased transient local membrane disruptions and inflow of calcium. So because calcium is released, activation of proteases occur, altered calcium channel activity, which increases the flow of calcium. So impaired calcium homeostasis occurs, results in apoptosis and necrosis. What are the clinical manifestations? Shoulders and arms are held back awkwardly and while walking. Sway back, weak butt muscles, knees may bend back to take weight, thick lower leg muscles. The muscle is mostly fat, it doesn't contain that muscle strength. Okay, tight heel cord, that is contracture in the child. It may walk on toes, that's the reason. Belly sticks out due to weak belly muscles. Thin, weak tights, especially front band. Then poor balance, weak muscles in front of leg cause foot drop and tiptoe contractures. So usually the onset is 3 to 6 years. Progressive weakness occurs. Pseudo hypertrophy of cardiac calf muscles, spinal deformity, cardiopulmonary involvement. So mild to moderate MR can be seen. So initially there will be walking problems. You need to pick it up. So any pediatric age group, when you are seeing the child, if they are having any walking problem, kindly rule out Duchenne muscular dystrophy. Then later stages, that is 15 to 25, wheelchair, skeletal deformity, limited use of arms, ventilation at night. That's all at the later stages. So diagnosis, how we are going to diagnose? The child has got some abnormal gait, Ober test, Thomas test, they're all positive Maron sign. The child slips through the truncal this thing. Then myocardial deterioration, IQ will be around 80. So biochemical parameters, that is there is increase in creatine phosphokinase, myopathic change in EMG, then degeneration, muscle degeneration can be seen on biopsy. Immunoblotting can help in detection. Then DNA mutation analysis can be helpful. You can identify that there is absence dystrophin. So there is not just one way to treat muscular dystrophy. Treatments also includes physical therapy, assistive devices, medication, and surgery. Second one, that is Becker muscular dystrophy. So Peter Emil Becker, he was a German doctor. So it's a milder version of Duchenne muscular dystrophy. Here also single gene defect occurs on the short arm of X chromosome. So there's altered size and decreased amount of dystrophin. See the difference between Duchenne muscular dystrophy and Becker. It is in Duchenne muscular dystrophy, it is completely absent. Dystrophin is completely absent, whereas in Becker's it is decreased, and because of frame shift mutation here. So in normal extracellular matrix, dystrophin it bridges the cytoskeleton to extracellular matrix. In Becker's, partial function is present, whereas in case of Duchenne's, there is no connection itself. So complete absence of this connection to the extracellular matrix. Clinical features. So family history of atypical muscular dystrophy, similar but it is less severe than Duchenne muscular dystrophy. Pseudo hypertrophy of calf muscles are seen. Equinus varus of the foot. High rate of scoliosis. Less frequent cardiac involvement. Its diagnosis, it is same as Duchenne muscular dystrophy, wherein there is decrease in the dystrophin and there is increase in the CPK. Natural history shows slower progression, ambulate until adolescence. Longer life expectancy can be seen. Treatment almost same as Duchenne muscular dystrophy. So you have to release the plantar muscles if there is any forefoot equinus, and wedge osteotomy if there is midfoot dorsal. So this is a summary of all the muscular dystrophies, but important for you is Duchenne muscular dystrophy. It is sex-linked recessive inheritance, muscle involvement proximal to distal, muscle spread, that is leg, hand, arm, face, larynx. Okay, so age group is 3 to 6 years, more commonly seen in male. This is important for your exam. So pseudohypertrophy, it is seen in 80%, mainly calf muscles. Contracture, it is seen. Scoliosis, kyphoscoliosis are commonly seen, but usually late. Heart, cardiac hypertrophy can be seen. Intellectual, it is decreased, and course, it is steady and rapid. So you need to take some muscle biopsy. You have to do some special stains and IHC for finally coming to a diagnosis, mainly dystrophy. So treatment is generally aimed at controlling the symptoms and mainly to improve the quality of life of the patient. So the next topic is about myasthenia gravis. All of you know about myasthenia gravis. It's an autoimmune disease in which antibodies they bind with acetylcholine receptors on muscle cells, mainly the T lymphocyte abnormalities. It reduces the number of acetylcholine receptors at the neuromuscular junction. It is characterized by muscle weakness and fatigability. It's also associated with other autoimmune disorders such as SLE, rheumatoid arthritis, and thyrotoxicosis. In 10 to 25% of the people that have thymic tumors, 78 to 80% have pathological changes in the thymus. What's the pathophysiology? Here you already know that there are antibodies which are directed against acetylcholine receptor at NMJ. So this image you must have seen many times. This is the NMJ, this is the nerve terminal, this is the muscle fiber. You are seeing acetylcholine fibers. This is the muscle membrane. So antibodies are directed against this acetylcholine receptors. So clinical manifestations, ocular motor disturbances, mainly ptosis, drooping of eyelid or diplopia can be seen in most of the cases, around 90%. Then oropharyngeal muscle weakness, difficulty in chewing, uh, swallowing or talking, severity of weakness, it fluctuates during the day. So no sensory or reflex loss, muscle atrophy is rare. So myasthenia crisis, it is defined as respiratory muscle weakness that is severe enough to necessitate intubation or delay extubation. So what is that cholinergic crisis? Anticholinergic drug toxicity, intestinal motility increases, fasciculation, bradycardia, pupillary constriction, increased salivation, increased sweating. So what are the treatment? What is the treatment? The treatment which is given are anticholinergic drugs, steroids, immunosuppressant drugs, cyclophosphamide, plasmapheresis during myasthenic crisis, and thymectomy. It's treatment of choice for individuals with thymoma. So thank you. That completes this musculoskeletal system. So important things in musculoskeletal system. What all you need to read are, one is this osteoarthritis, rheumatoid arthritis. You should know the pathogenesis and what are the histopathological findings and clinical features. Then you have to go through this bone tumors, especially osteosarcoma. Most commonly it has been asked. You should be knowing the risk factors. That is the pathophysiology again here, and also the histopathological findings. Then inherited disorders and all. If you glance, it is. I think it will be sufficient. Okay, these are the important topics in chondrosarcoma also, and very rarely they can ask this muscular dystrophies. Okay, thank you very much.